Hi, this is Dr. Penny from University of Malaya. Plate Haptic IOL Explantation, tips and tricks everyone can do. In life, no surgeon would like an IOL explantation experience after a successful cataract surgery with IOL implantation. However, it's inevitable in certain conditions. For example, damage to the lens during the insertion procedure, refractive surprise, IOL dislocation, IOL decentration, or pacification of IOL, or intolerance glare and halo. In this video, I am sharing the common mistake that we made, tips and tricks, and an easy way to explant plate haptic IOL. This patient has both eyes high myopia, underwent IOL explantation due to refractive surprise. This explantation surgery was planned after 1 week post-operation. It's advisable to proceed with explantation before IOL capsular bag adhesion. First of all, make sure pupil is well dilated. This will facilitate your IOL explantation and it can minimize iris manipulation that induce unnecessary iris pigment deposition in new IOL implantation later that might compromise your visual acuity. In this patient, I give intracameral preservative-free lignocaine 2%. Inject some OVD beneath IOL to expand and protect the PC. Adhesion is unlikely in post-op 1 week patient, but similar method of viscodissection apply if there is adhesion. Tips number 1. Do not overload the OVD in the bag and trying to dislodge the IOL by only injecting lots of OVD behind the lens. Overloaded OVD causes iris prolapse and it makes whole surgery becomes more difficult. Forcefully dislodge the IOL can cause anterior remorasis tear. Instead, use a simple instrument, lens dialer, to lift up the trailing haptic gently out from the capsular bag. Extend the main wound minimally on both sides, about 1 to 1.5 mm each. And now you may think, shall I explant the IOL straight away like you can see in this video? Not recommended. You might cause resist rim tear, especially on the leading haptic side. Mistake number 1 here. Holding the lens at the optic haptic junction can cause IOL breakage. What's the better option? We should lift up the leading haptic gently with lens dialer and place the whole lens above the iris plane. Always remember to inject OVD to protect corneal endothelium before lens explantation. Rotate the lens into oblique position in which one of the corner of the IOL near to main wound incision. There is the other challenge you will encounter during explantation. The moment you open the forceps in attempting to hold the IOL, the forceps opening itself can push the lens downwards, limited space for your forceps to reach the optic of the IOL, inadvertently touching the iris and shallowing of the AC. How to overcome this? Extend the side wound now, just adequate for you to insert the iris repositor. Gently insert the iris repositor between the posterior surface of the lens and above the iris. This method can avoid the lens being pushed down while the lens is grasped by the forceps and also protect the underneath iris at the same time. Hold the optic of the lens firmly with implant removal forceps. Pull it gently across the wound and it's removed completely now. I prefer to explant the IOL first and visualize the intact PC before lens implantation. Tips of injecting plain haptic IOL without the need of dialer is: place the injector in the center of the bag, inject the lens gently and hold in this position and location till the whole lens is expelled completely. The whole IOL is secure in the bag now. One suture is applied at the main wound in this patient. However, this is not compulsory. In summary, in the event of IOL explantation, we pay attention to several factors in planning surgery to achieve a good visual outcome. Reserve the intact capsular bag, protect the corneal endothelium, and not to induce high post-operative astigmatism.